Good morning, everyone. We're going to get started with our meeting. So I'm Maggie Zellner, and I'm the president and chair of the Neuropsychoanalysis Foundation, and we support the Arnold Pfeffer Center, which is where you are now. So our meeting this month is really a very interesting departure from our typical format. Typically we have one speaker, and today we have a panel of young researchers. And there's several reasons why we're doing this panel. So one is to support the development of neuropsychoanalytic research. The idea being that doing research between neuroscience and psychoanalysis is sort of good for the world in a number of different ways. We think that it allows us to test psychoanalytic concepts in a new domain. It can also help us to refine our psychoanalytic theories, and it can also, in the opposite direction, our psychoanalytic understandings of the mind, we think, can really enrich ongoing neuroscience research. So this is sort of an interdisciplinary space that we think is going to be productive for both sides of the dialogue. And since most of you guys are sort of frequent flyers at this lecture series, I don't have to sort of promote the benefit of neuropsychoanalysis to you. But also another thing is that the more we can get good empirical research published out there in the literature, it's both important for neuropsychoanalysis, but it's also important just for psychoanalysis, we think. Some of us, even though the critique has been raised that doing research for the purpose of proving psychoanalysis is not a good agenda for research, but I would question that. I think that actually, if we really believe in psychoanalysis as a theory, as a form of treatment, then having empirical evidence that supports our concepts can really only help psychoanalysis out there sort of in the popular culture, as well as in the scientific realm. So the aim of today's panel, we think, is going to serve several functions. I think from an education point of view, it's going to be very interesting for all of us. All of the topics that our panelists are doing research on has direct clinical relevance, so I think you'll all find it interesting from that point of view. We've asked the panelists to, give a nice sort of overview of the background of their research questions, so we're going to sort of be getting mini tutorials in some different kind of topics. And then also it's a chance for those of us who are not engaged with research at the moment, but who might have a little curiosity about it, to see what's involved in developing a research project. Some of the research that you're going to hear about today is still really in process. Some of the projects are not even yet quite at the data collection stage. So it's really at the stage of thinking about a psychoanalytic concept, doing something called operationalizing, which is thinking about how do you take this very complicated concept, whatever that might be, in psychoanalytic theory and practice. How do you identify some of the key features of it, and then how can it be measured? And then how can you put it into some kind of experimental situation so that you can control for the variables? So we get to see, sort of as these guys tell us how they've been sort of structuring their research, how they've been thinking about it, we get an insight into actually how research is conducted. And I hope that that will be interesting from a number of perspectives. And then finally, because most of these projects are very current and are still, some of them in the developmental stage, it's also an opportunity for them to get feedback from the rest of us about what we think about how they've operationalized their concepts, other things about their research design, and I'm sure they're all will be interested to hear that feedback, either for the current project or for future work. So with that said, I just want to offer one caveat, especially to those of you who are strictly clinicians and who don't have sort of a background in doing experimental research. And I want to prepare you that this is going to be emotionally challenging, as some of our presentations are. That when our presenters have taken a psychoanalytic concept and operationalized it, it means really boiling it down and super simplifying some aspect of that process. And I think that everyone in the room can accept that those things, as they actually live in the mind and in the psyche, are actually extremely complex, are influenced by a number of variables in any given individual's life. But for the purposes of research, we have to simplify it, right? So just from the outset, I want everyone to get prepared that you're going to be like, how can you take that concept and, boil it down like that? So, but in the question and the feedback time, certainly if you think that they've operationalized it incorrectly or there's something missing, that's a very good piece of feedback to give. But just saying you've oversimplified it is sort of not really in the spirit of doing experimental research, if you know what I mean. Okay, so with that said, what I'm gonna do to facilitate a flow for the morning, I'm just gonna give you a brief bio for each of our speakers, and then they'll each give their presentation. So they're each gonna present. I'll take a few questions from the floor about each talk, and then at the end, all of the speakers will come up and we'll have open discussion and questions. So first on our panel is Eric Fertuck, who received his Ph.D. in psychology at Adelphi University, and he's currently an assistant professor at the City University of New York in the psychology program. He's also affiliated with the Columbia University Center for Psychoanalytic Training and Research, and he's also a researcher at the New York State Psychiatric Institute. Then next we'll have Jeff Erbe, who got his M.Sc. at the joint program between Yale and the Anna Freud Center and the University College London in neuroscience and psychoanalysis. And he's currently a doctoral candidate in clinical psychology at the City University of New York. After him, we'll have Luis Ripoll, who received his M.D. from the University of Florida, and he's currently a research fellow at Mount Sinai and at the Bronx Veterans Administration. And he also recently was a research fellow at the American Psychoanalytic Association. And then our last speaker will be Paul Siegel, who got his PhD in psychology also at Adelphi. And he's an assistant professor of psychology at SUNY Purchase. So I think you can just hear from the brief bio descriptions that that these guys have very interesting multidisciplinary training, and I think we're going to have a really good program this morning. So we'll start with Eric. Oh, and let me also just say that Eric Fertuck is a recipient of one of our most recent research grants. The Neuropsychoanalysis Foundation supports neuropsychoanalytic research, and he got one of our grants for this year. So we hope he measures up to our high standards. Just kidding. We know that you do.
No pressure.
Okay, no pressure. There you go.
Okay, thanks. Okay, thanks, Maggie. Can everybody hear me? Yeah. How's that? So thanks for coming out on Saturday morning, and this is a great idea for a panel, and I'm so glad that Maggie had the idea to put us all together. And I'm going to be talking about an aspect of borderline personality disorder, which, as most people in this room probably know, has deep psychoanalytic roots, but has come of age of late, at least according to some, including Glenn Gabbard. He, in the last year or so, wrote an editorial in the American Journal of Psychiatry about the growing interest in this disorder, not just from psychoanalysis, but from a wide range of perspectives. This has not been lost on even our House of Representatives. A couple of years ago, they passed a resolution designating May Borderline Personality Disorder Awareness Month. And in addition, even Time Magazine has been writing feature stories about this disorder. So what is borderline personality disorder, at least in the current diagnostic nomenclature? It's got 9 criteria in the DSM, but these can be kind of categorized into 3 symptom clusters. One is disturbed interpersonal relatedness. The other is, this is characterized by these difficulties in relationships, identity problems, feelings of emptiness. Emotional instability, usually characterized by intense negative emotional reactivity to perception of what's happening in relationships and other environmental events. And in the context of a relationship, there's often a frantic attempt to prevent somebody from abandoning them. And finally, there's a behavioral instability that is embedded in all these emotional and interpersonal problems, often taking the form of self-injurious behavior that may or may not be suicidal in its intent, and other forms of impulsivity that can be reckless and put the individual at risk. It seems from fairly good epidemiological studies at this point, about 1% of the general population has this disorder, at least by the DSM criteria. This is comparable to, and even a little bit higher than things like schizophrenia, and most of the people who come for treatment for this disorder are female. But when you do these epidemiological studies and, in essence, kind of knock door to door randomly and assess people in a community setting, the gender distribution is about equal. So we're missing some men in the clinic, but when you actually apply these criteria in the general population, it does not seem to be a particularly gender. There's not one gender that seems more represented than another. The risks of borderline, as I've alluded to, are about 10% of people with this disorder end up ending their own lives, which is comparable to other psychiatric conditions like major depression, bipolar illness. In addition, about 75% or so, depending on where you draw your sample, engage in some form of self-injurious behavior, self-cutting, burning, some sort of tissue damage. Again, this may or may not be with a suicidal intent. Often people who do this describe that it helps them to down-regulate negative emotions. So what am I going to focus on then? Or what aspect of this disorder have we tried to kind of highlight for empirical and neuropsychoanalytically oriented investigation? We've been looking at social cognition. In particular, we've been looking at two aspects of social cognition. One is the capacity to appraise trustworthiness in social stimuli like faces, and we're comparing that kind of an appraisal to the capacity to appraise an emotion, such as fear. The first, trust, we consider a trait appraisal, and a trait is an aspect of somebody that you expect to be relatively stable over time, to have some predictive information about how you can expect them to be in the future and in different contexts, whereas an emotion appraisal is really just how someone seems to be feeling in a particular moment. And this is derived by reading certain cues, like their tone of voice, their facial expression, their posture, their verbal, what they're saying, what they're telling you. So in the study I'm going to present, we've actually designed it so that we're measuring trust appraisal at the same time that we're measuring fear appraisal, so that we can see the similarities and differences between those two types of appraisal process at both behavioral, psychological, and then neural levels. We suspect this is an important distinction in borderline personality disorder as well, because the capacity to trust other people seems to underlie a lot of the concerns with abandonment, negative therapeutic alliances, enactments that you see in the treatment of these folks, premature terminations from treatment. They often describe feeling very, very disappointed and hurt, and often after somewhat idealizing therapists and other people. So there's some clues in the current literature that this is an important concept to study. Nelson Donegan and colleagues a few years ago did one of the first fMRI studies in borderline personality disorder, and they presented patients and controls Ekman faces of different emotional valences, from neutral to fearful and in between. And they focused on the amygdala, which is a region quite closely tied to emotional processing, the salience of the emotional salience of stimuli. And what they did is they had participants in this study passively view these Ekman faces, and then they looked at neural activation between the two groups to see if they differed. What they found was that basically across all the types of faces, from neutral up through fearful, The borderline patients had much greater amygdala activation than the controls, but particularly of note in the neutral, that's this one, and this is the controls neutral activation of the amygdala. There basically isn't any, but in the borderline patients, there's a pronounced amygdala activation to the neutral faces. And anecdotally then, what they did is as the patients came out of the scanner, they would ask them anecdotally what they thought of these faces. And here's some of the quotes that are reported in their paper. They look like mugshots, like someone who just got arrested. They look fake or like a facade. They're hiding something. They look like they're plotting something. So this gave us a little sense that the concept of trustworthiness or the appraisal of trustworthiness in these faces was something important in understanding this patient population. So we've been looking at that in the context of a couple of things. One, the degree to which that might be related to rejection sensitivity in this group. And we have taken a measure of rejection sensitivity that is from the social psychological literature developed by Geraldine Downey and colleagues. It's called the Rejection Sensitivity Questionnaire. It's a well-established and valid self-report measure of anxious expectations of rejection from significant others. It's a very straightforward measure that just asks individuals about 9 hypothetical situations. Here's a sample item. Lately you've been noticing some distance between yourself and your significant other, and you ask him, her, if there's something wrong. The participants then respond on a Likert scale to these 2 items. To what degree would you be concerned or anxious, whether that person would still love you and want to be with you? That's the anxiety portion of the scale. And then the second is I would expect that he or she would show sincere love and commitment to our relationship no matter what else may be going on. This is the expectation aspect of the scale. These 2 aspects of the scale get scored to derive a total score, which is a combination of these 2. But you can also look at each of these subscales differently. So you can look just at the anxiety aspect or the expectation aspect. So in addition to that measure, we've been developing a task to look at trust appraisal. And our goals in developing this task was to independently assess trust as a trait and fear as a mental state or emotional state. We were sure for the trust part to only use neutral faces. Some of the prior research on trust appraisal has used emotionally valenced faces, making it hard to disambiguate a trust appraisal from emotion appraisal. So for example, if someone uses an angry face, it's hard to know if they're responding to the anger in the face or whether the person's actually trustworthy. And then we were also very sure to measure reaction time, which hasn't always been done rigorously in prior research. And then, as I mentioned, we're also looking at these social cognitive processes in the context of personality traits. So here's some of the stimuli we then developed. What we did is we took a bunch of neutral faces and had a sample of controls rate those faces for trustworthiness. And what we did is we selected out the faces that were consistently seen as really trustworthy by most people or really untrustworthy by most people. And so this is an example of one of the faces that was seen by most people as relatively trustworthy. And this is an example of a face that was seen by many people as untrustworthy. And so with these 2 extremes, and we had 8 at each extreme, 4 men and 4 women, we use a program called Morpher, which actually allows you to morph faces to convey mixtures of the features of each face at different percentages. So what this program can do is generate images that are, for example, 80% untrustworthy and 20% trustworthy, or 50% and 50%, so that you have then a kind of a parametric dimensional rating of trustworthiness, or at least of a trustworthy signal. At least that's what we hoped. So a 50% morph of these 2 faces looks something like this. So with this then wide range of stimuli, we had our stimuli for the trust appraisal task. And then we did the same thing using the same actors as we used for the trust faces to develop morphed fear faces. So we took their neutral face and we morphed it with their fear face So this on the right is an example of their fear face. And this is a 50-50 mix of those two. So we then also had 10% increments of these stimuli as well. So we developed a task out of this that can be used either in the scanner or outside the scanner, where these faces are shown randomly. When each face is shown on the screen, the individual has a 5-point scale on which they rate their impression of whether that face is trustworthy or fearful, whichever one they're rating at the moment. And what gets recorded is their rating and their reaction time, how long it took them to make that decision. And we show literally hundreds of these faces to folks in various aspects of the study, so we have a lot of observations. So our research questions then with this task were, what types of differences in trust appraisal are present between borderline patients and controls? Are these differences due to a general emotion recognition deficit, or are they specific to trust appraisal, which is really a trait appraisal, not an emotion appraisal? So for example, we might see a trustworthy deficit appraisal that is driven essentially by an emotion recognition deficit, so that it's a kind of more general social cognitive deficit. It's not specific to trust. So we wanted to be able to differentiate those two processes. And then for the fMRI aspect, we wanted to know, do trust and fear appraisal involve the same or different neural systems? And then secondly, are BPDs and controls differences in any appraisal process due to different neural activity? So the first data I'm going to show you is from a sample of individuals we did outside the scanner, and we just had them do the task. This just suggests they're fairly well matched on these variables, and none of those variables, demographic variables, predicted performance on this task. So the second slide is the rejection sensitivity scores. Indeed, we can show that the borderline patients in the red are exhibiting much more self-reported rejection sensitivity, which is particularly reflected not so much by their anxiety over rejection, at least in this sample, which is curious, but by their expectation of rejection. But when you combine those two scores to derive the total score, the overall rejection sensitivity is much higher in the borderline patients. So then this is the data for the task that I just showed you with those faces. On the left, what you can see on the y-axis is their rating on average. And the high rating means they see less trust in the face. At the bottom is the lower rating, which means they see more trust in the face. And these are, again, all neutral faces, you saw them. And then on the x-axis at the bottom here are those morphs I talked about. So from 0 to 100% morph. And so we have 10% increments. So these reflect those mixtures of the two extremes of faces. What you can see is that in the red is the borderline patient's average responses across all levels of morph. You can see that they are an order of magnitude higher, which means that they're on average seeing all the faces as less trustworthy than the controls. So there's a systematic, this would be called a bias. There's a bias in these patients to see all these faces as less trustworthy. However, there's no difference in the sensitivity to the stimuli or the discriminability, at least in these stimuli. So keep that in mind while I walk you through the figure on the right, which is the same analysis, but it's the fear stimuli. So these are the faces that were morphed from neutral to fearful. You can see that this is their average rating. In the red is the patients, and then the black are the controls. There's essentially no difference in the rating at all levels of morph for the fear. So there doesn't seem to be any deficit in the patients in rating fear from faces. They're doing it just as well as the controls. And so there does seem to be something quite specific happening when rating trust with these patients. Hopefully that's all clear. Next slide is the same stimuli, the same study, but this time we're looking at reaction time. So that's how long it takes people to say they either trust or fear a face. And on the y-axis here is the reaction time itself on average across different ratings on the x-axis. So this is the 1 to 5 rating on the x-axis, and then the and on the and compare as referenced against reaction time. Again, the red is the patients, and the black is the controls. You can see that in the trust appraisal, as you move towards rating the face as more trustworthy, that is closer to 1, reaction times for the patients are longer than for the controls. So it's taking them longer to decide that they trust somebody, particularly as they lean towards saying, yes, I do trust this person. In contrast, in the fear, you don't see quite the pronounced difference in reaction time. In particular, and as the face is more fearful looking, there's no difference in reaction time. So they're taking the same amount of time to say that a face looks fearful when it's clearly fearful. But as it moves towards looking more neutral, again, you see a little bit more delay in the patients. It's taking them a little bit longer. Keep in mind that it's actually starting to look more neutral as it moves towards the lower rating. So you can speculate that there's starting to be some interference with trust appraisal going on that's making them hesitant to be able to make a very clear emotional judgment. So we've taken this task now into the scanner and have some preliminary data about what's happening with these patients and controls when doing this task at the brain level. This is an fMRI study. We have a borderline sample for this study that's all female. We wanted to reduce heterogeneity. They're off medications. They don't have current PTSD. They're not currently in a major depressive episode. They don't have any co-occurring diagnosis that might be a confound, like bipolar diagnosis. Most borderlines have some sort of co-occurring disorders, but we tried to rule out the ones that would be most confounding. We ruled out PTSD, for example, current PTSD, current substance use, all these kinds of things. So what we then had them do in the scanner is alternate between doing runs where they would be rating trust or fear, and to get enough data points for adequate analysis of the fMRI data, we had them do each one 3 times in an alternating fashion. So they were essentially rating faces for over half an hour in the scanner. And here's what we found when we look at all the patients and the controls together in one group, and we wanted to know which brain regions are mapping with or responding to, or where is neural activity correlated with rating of fear versus trust. So on the left, what you see is the activity that's modulated by perceiving more and more fear in a face. So as someone sees more fear, you see more amygdala activation. This is quite consistent with many studies in the literature at this point. One of the reasons we chose fear is so that we could be able to know if we were kind of on track, and we could refer to a fairly well-established body of literature about fear processing at the brain level. And on the right then, it's the same analysis, but this time rather than looking at the correlation with the fear rating, we're looking at correlation with the trust rating. And what you see is it's not the amygdala, it's predominantly the orbital frontal cortex. So as people are seeing less trust in a neutral face, you see more orbital frontal cortex activity. This is across all whether you're a patient or a control. So the next analysis we did then is compared the 2 groups. So are there differences between the 2 groups in brain activation when making these kinds of appraisals? And consistent with the behavioral data, we didn't see any, at least in this early stage, any brain activation differences when rating fear in faces. But we did see brain activation differences when rating trust. And this is what we found. Again, what you see is that the borderline patients have more orbital frontal cortex activity when rating trust than the controls. This is consistent with the orbital frontal activation we saw that tracked with trust appraisal. And in addition, you recall that the behavioral data was that there's a bias towards seeing less trustworthiness in the faces and a longer reaction time as the face became more trustworthy looking to the patients. So all of this together suggests to us that the orbital frontal cortex seems to be underlie some of these appraisal differences that we see in borderline patients versus controls. What we know about the orbital frontal cortex is that it's very involved in reward processing. So it has neurons that code for both assessing potential rewards of stimuli and potential risks of stimuli. Oh. Looks like it's shutting down. Here we go. I'm almost done anyway, but I'm sure they need a PowerPoint too. What we're speculating at this point is that the orbital frontal cortex in these borderline patients with regard to trust is that either they're over-evaluating risk or reward or both, perhaps in an approach avoidance conflict when evaluating trust, and that this kind of a decision for them is so powerful and so salient that they are recruiting this region to a greater degree than controls. This fits with the rejection sensitivity of this patient population and a lot of the interpersonal turbulence that you see both in the therapeutic relationship and in their other relationships. So just to summarize, we're seeing altered and biased trust appraisal at behavioral and neural levels in borderline patients. This may be related to heightened rejection sensitivity. We don't see a corresponding difference between them when rating an emotion, fear. So this seems quite specific to trust. And just a little note on clinical implications of these findings. Paul Ekman, who most of you probably have heard of, he's one of the pioneers of facial emotion research. He was actually trained as a clinical psychologist at Adelphi, and he had an interesting quote in an interview a couple years ago where he described his motivation to study faces. And what he said was interesting. He said, by both doing and observing psychotherapy in his graduate training, I became convinced that there was an awful lot in the face and the body apart from the words, and if we were to really understand the process of psychotherapy, we need to be able to measure it. Little did I know how long it would take. He's now in his 80s, I think. He's been studying the face for his whole career. So what might this tell us? What are some implications for us to think about as clinicians and psychoanalysts? Well, maybe this helps us understand something that was kind of discovered clinically many years ago, which is that people with borderline often don't respond that well to the couch. They regress, they become very paranoid. Sometimes it's hard for them to reconstitute after sessions. And so borderline patients are now most predominantly seen face-to-face in a less frequent, often a less frequent therapy to prevent this kind of regression. Negative or paranoid transferences are going to be common, and they need to be probably a therapeutic focus. These people just have a bias towards not trusting people, especially when there's not that much information to go on, when things are ambiguous. In transference analysis, I think it's important to differentiate. I didn't get the chance to go into some data we have, but we have some data that with certain social stimuli, borderline patients are actually hyper accurate. So as clinicians, we need to be aware of differences between projecting, like an untrustworthy attribute to the therapist versus them accurately reading something in you that you may not yourself even be aware of. And that this is often a complicated dance when working with people with borderline personality disorder. So the future directions for this research are that, as Maggie mentioned, we have a grant to start studying the interface of social and physical pain in borderline. So these are folks who are sensitive to rejection, but also in response to rejection, physically injure themselves often, and they report that this helps them to feel better. So we want to understand more the mechanism behind that process. At the brain level, there might be overlapping brain systems that these patients are, through this self-injurious behavior, recruiting to downregulate social pain. And hopefully I'll be able to tell you guys about that at some point in the future. And then secondly, and this segues to Jeff Erbe's talk, we've started measuring quality of object relations and attachment style and attachment categories in these patients, so that we can get a sense of the representational world of these patients and use that to help us understand some of these behavioral responses to trustworthiness. So this is just a mention of our collaborators. Barbara Stanley is the mentor on this. Most of this is supported by a Career Development Award from NIMH, but in addition, the Fund for Psychoanalytic Research of the American Psychoanalytic funded some of this work. And these are all the people who have either collaborated or advised or consulted with me on various aspects of this project. So that's it. Thanks for listening.
Testing, yeah. Okay. So we'll just take 2 questions from the floor on this specific talk.
Very, very interesting. 2 related questions. One is, how do you select your subjects, both your controls and your borderlines? And how long do they spend in the scanner for each study?
Well, the borderlines, I mentioned some of the inclusion-exclusion criteria. They have to meet DSM criteria for borderline personality disorder. They have to not meet for certain other disorders that I mentioned. And they can't be in a current depressive episode. They can't be currently on meds. But the most important thing is that they're unambiguously meeting the DSM criteria for borderline personality disorder.
You advertise for them, and how do you get them?
We advertise. We either get them through other studies in our division at New York State Psychiatric Institute. We have a lot of success with Craigslist, surprisingly, or maybe not so surprisingly. And we get referrals from clinicians who are colleagues of ours who have patients who may be interested in participating. So various sources, and we pay. We pay them, so there's some incentive for them to participate, and many of them don't do it for money, though, I don't think. In fact, I forgot to mention that I really appreciate, this work can't be done without this work can't be done without their participation, so I really need to acknowledge those efforts. And how long are they in the scanner? So we have a couple tasks that they're doing. This is just one of them. This one takes about a half an hour. Then we have them do a social rejection task, which takes about another 20 minutes. And then we do a structural scan where we just have a 2D image that's high resolution so that we can map on the functional data, and that takes usually another 10 minutes. So they end up being in this. The scan is operating for about an hour. There's setup and time to get them out and stuff, so they end up being in there a little over an hour, but that's about how long.
In terms of your controls, it seems that it's also possible to interpret the controls as attaching less importance to physical features when making determinations of judgment or in terms of trust or fear. For just taking one example out of the headlines, Mr. Madoff, I'm sure he had a very trustworthy face, and he cultured it to a certain degree. So trustworthiness and fear also depends on an extended experience with a particular face and a particular person. There's going to be some people that say, no matter what, I still don't trust him, that sort of thing. So do you feel that your controls in a certain way may have been undersensitive to facial features for reasons of culture or educational adaptations, things like that?
That's a great point.
Okay.
Should I respond to this first? Or?
I have just one comment. It's very interesting research because the stimulus that you're using is basically a neutral stimulus. That is, there are different expressions on the faces, but no one knows if they're really angry or not. These are just photographs, and so it's all coming from internally from the person, and that's what's so terrific about this particular thing. The same way in the therapy situation, we hope that the person is reacting to their fantasy of us. Of course, we know that we are really doing things and there's some reality, but we hope they're reacting to their internal stimuli, not to the external stimuli. And I think you're also showing that at first it seemed as if trust and fear would be the two extremes of one quality, analogous to what Erickson said is the task of the earliest stage of development. But maybe there is some subtle difference here, because it's not more or less activation of one part of the brain. It's two separate parts of the brain, so maybe they're not a part of the same continuum.
Yeah, that's a great point. I mean, I can't help but start thinking of, what happens working with these folks in the transference, and you're often contending with all kinds of negative attributes that they're construing in you as a therapist, and that's why I like these stimuli as well, because they end up being projective stimuli that are. And also because you don't know these people, they're total strangers. It's all what you're bringing to the situation. So that's both the strength and the weakness of this approach, which is that they actually have no idea whether these people are trustworthy based on any actual experience with them or knowledge about them. So that might be the next step, is trying to start manipulating those aspects, the contextual aspects. So for example, borderline patients might have difficulty, once they decide someone's trustworthy or not, shifting with new information. This is often considered splitting or something like that. So they might, once they land on an appraisal, it's hard for them to shift gears with new information. I forgot to mention the control groups. We screen the controls for any current or past psychopathology in terms of having a DSM diagnosis of some sort. And we also screen them for drug use, any evidence of lab work for any substance use.
Thank you very much.
Good morning. Can everyone hear me? Okay. So before I start, I'd just like to say that I've been attending these meetings for the past few years, and I find this to be an exceptionally inspirational forum to talk about the ideas of neuroscience and psychoanalysis. And so I want to thank the organizers for putting this together today. Before I start my talk, I should also mention that I've been working with Dr. Fertuck on his project for the past year and a half. So a lot of what I'm going to be presenting is an extension of that core project. So you want to keep those ideas in mind. I should also mention that the project I'm going to present to you is the development of my dissertation work that stems from the original project. So the title is Mental Representation, Social Cognition, and Functional Neuroimaging, a multi-level approach to borderline personality disorder. I'd like to first acknowledge Dr. Fertuck and Dr. Diamond, my two primary mentors on the project, also everyone in Barbara Stanley's lab at PI, and Joy Hirsch's lab at Columbia, also my colleagues in clinical psychology at CUNY, and the research fund from the International Psychoanalytic Association that's funding this. So a little bit of background. The premise for my thinking about this project is really that we want to understand the human subject in as much complexity as possible. So it's one thing that we can take our clinical knowledge from psychoanalysis and rich understanding of subjective experience and the dynamic unconscious and see how we can relate it with the information that we're gaining from neuroscience and modern empirical techniques that allow us to look at biological and psychological processes in great detail. On a more personal note, I often feel that when I'm watching someone present empirical research that I want to know something more about what that participant's experience is like. So that's what really inspires what I'm going to be talking about, which is about getting narratives from these participants. Just as a little bit of background, social cognitive neuroscience is a field that's really blossomed in the past 15 years or so. Matthew Lieberman out of UCLA wrote a review of this in 2007, and we've seen a development in the sophistication of the methods and the approaches that we use in this field. There's also been a long-standing history of social cognition studies in borderline personality disorder. This dates back to the 80s with Drew Weston's work using projective measures with a variety of patients, definitely with borderline personality disorder patients. And the techniques have only become more complex experimentally. Fewer of these studies of social cognition of borderline personality disorder have employed neuroimaging methods, but that's been gaining a lot of momentum as well over the past 10 years or so. And no prior research in borderline personality disorder has simultaneously studied mental representation, social cognition, and neural activity, and that's what I'm setting out to do. So when we talk about mental representation, it's sort of a catchphrase, I think, in psychoanalysis a lot of times. But I think something that's fundamental about it is that we're talking about internalized, emotionally charged relationships. So one way of categorizing these relationships comes from object relations theory, which implies a broad range of object categories. So you could be talking about the self, you could be talking about father, mother, significant other. And another approach to mental representation comes from the attachment literature and looking specifically at attachment relationships as distinct categories of objects. Now I'm going to talk a little bit about the design of my project. So if you remember from Dr. Fertuck's talk, he was describing the face appraisal task. And that we're assessing people's responses to these faces in the scanner. So you see the first two levels here. The neural level that we're looking at comes from the fMRI and the brain activity. And then the social appraisal task of the faces is a second social cognitive level. The third level here is social behavior as measured by the Ripoll task. And he didn't really have time to get into this, but to give you a brief explanation, the Ripoll task is one in which the subject is laying in the scanner and they see their hand represented in front of them with two other characters at the top. And they're playing a game of catch with those people, and we tell them that we're playing them through a computer network. So they go through a round of playing this game, and it varies based on how often they're excluded. So how often they don't receive the ball, and they just watch the other two people throw back and forth. So after they go through the task, they measure how they felt. And with the borderline patients, we see that they rate themselves as experiencing greater rejection than healthy controls. So just to sum up this slide, the first level, this first line is the neural level, and then the second two lines is the behavioral or social cognition level of analysis. So my motivation for expanding this was, first we have these neural, psychophysical, and behavioral levels. But one particular quality of the task that we're using is that they're using generalized social stimuli. So the faces that are being rated and the cyberball game that's being played, it all has to do with social interactions that are depersonalized. So that's where I found that the mental representation derived from subjective experience was lacking. And to address this, I've added the object relations inventory, and we're about to add the adult attachment interview. Using these two measures, we can look at the developmental quality of representations of self and other, and we can look at the capacity for mentalization in these subjects. So the object relations inventory was inspired by psychoanalytic object relations theory and intersubjective developmental theories like those described by Stern. It was developed originally as a clinical research assessment by Sid Blatt and colleagues at the Yale Psychiatric Institute, and they want to understand the internally represented relationships between self and significant others. And what they discovered was that you could actually find changes in this inventory that were based on treatment. So after a certain amount of treatment, you saw that subjects were starting to represent self and objects differently. Specifically, the ORI is a semi-structured projective interview. So in this task, I sit down with the subjects and I'm asking them 5 questions. And in response to each of the questions, I give a 5-minute speech sample. So the first question I ask is, describe your mother. The second is, describe your father, describe yourself, describe a significant other, and describe a therapist. With these narratives, we can apply the differentiation relatedness scale, and this was developed by Diana Diamond and Sid Blatt and their colleagues. And what this scale gets at is really that it's a model of development where we think about psychological development progressing really towards increased differentiation and integration of the self, and that is always in relation on an interpersonal level that's based on, at higher developmental levels, mutuality and reciprocity. So this is a 10-point scale that assesses these capacities based on the narratives we collect from the questions. So here's one example of a borderline patient response when asked to describe her father. She says, a dick, 6'2", heavy, short black hair, real nasty, a real tyrant, beady black eyes. Why do you suppose he's like that? Because he's an asshole, sucks dick for a living. So this is given a rating of 4 on a 10-point scale. As you can see, it's pretty low. And the reason we give it a 4 is because it's an extreme characterization, it's one-sided, it's a total denigration of the father without any real reference to any context. However, what we can see after 2 years of psychodynamic treatment is a drastic change in the way this individual characterizes the father. So here she's saying, my father has a tough side to him, which he uses as a front a lot. He's very sensitive, and I think he feels bad about himself because he's had problems with drinking in the past. He's hard on himself, and he's got a very quick temper, but he's generous, and in his own way, he does care about his family, and he's really smart. So you can see this is a really drastic change that this instrument's able to detect. I should also mention that this now got an 8 on the 10-point scale, so to move 4 points is really quite a bit. So I won't have as much time to go through the adult attachment interview, which I'm hoping a lot of people are a bit more familiar with. But just to review, so this is a semi-structured clinical interview where we ask 20 questions with the patients that really get at having the patient think about what their childhood experience was of their primary caregivers. So they have to provide adjectives that describe the caregivers and go into great detail in thinking about what the quality of those relationships was like. So we give this interview to assess mental representations of the primary attachment figures, and we're able to analyze the narratives that we receive for capacity of reflective functioning and also attachment security and other trauma-related subscales. So now to bring our hypotheses together, to sum up with the ORI and the AAI, we predict that the borderline patients, on average, will show a lower quality of differentiation relatedness as measured by the ORI, and that will correspond to deficits in reflective functioning and other subscales on the AAI. And tying this back with the primary project, we think that the borderline patients who have these deficits are going to correlate with untrusting face biases, appraisal biases, high sensitivity to social exclusion in the cyberball task, and unique neural activation patterns, which we started to see from Dr. Fertuck's talk. The current status of this project is that we've had 32 participants now go through the imaging and behavioral protocol. So that's the face appraisal task and the cyberball and the imaging. And of those 32, I've collected 20 ORIs. We're beginning to transcribe, and soon we'll be calling the participants back to administer the AAI. So if you remember earlier, I presented these first 3 levels as the core project, and now you can see the bottom 2 for object relations and attachment representations as 2 forms of mental representation. If we put this in images, this is where we see the multi-level model come together. So on the left there, you see an image from Dr. Fertuck's talk that shows the differential orbitofrontal activity in the borderline patients for the trust appraisal task, and that corresponds with the trust bias, the distrust bias of the patients there in red. So on the far right side, there's arrows from the borderlines going up to the lower end of the ORI and the AAI subscales. Okay, so that's where the hypothesis comes in, that we think that they're going to show lower developmental quality and differentiation relatedness and lower capacity for reflective functioning, whereas the controls are going to, on average, score higher on those scales. Then down the road, hopefully we'll be able to speculate and design further experiments to tease apart greater detail in these processes and look at how the narrative qualities in these participants may or may not have direct influence on neural activation and behavior. So a few concluding remarks. So I think traditionally there's been sort of this false dichotomy between quantitative and qualitative types of research. And I think that this design demonstrates that really you don't have to have that you can incorporate both together. And this can really serve to further the discourse of psychoanalytic views and biological views on the human subject. This will give us a greater understanding of the interaction between neural, behavioral, and narrative levels of data, and will increase our knowledge of key interpersonal processes in borderline patients. So really to help us start to understand the mechanisms underlying the suffering of these patients. And in part, the way that I'm seeing this work is that it's taking the principle of listening to the patient's narrative and really giving back that emphasis on language. So at the end of Dr. Fertuck's talk, he had this quote from Ekman that says, you know, we need to look at how people are perceiving others in their environment. And I see this project bringing the language back into it so that we don't have to look at you know, these visual forms of social interaction at the exclusion of the language. And ultimately, gaining a better understanding with these patients and what's going on, what underlies the interpersonal problems that they have, will hopefully help us in advancing our clinical techniques. Thank you.
I'm not sure I even need to this question, but I'm going to ask you anyway. I gather that one of the implications of this work is that there is an inborn tendency in these patients to do all these things you're talking about, and then something in the real world may provoke them, but the neurological stuff comes prior to that, right?
What do you mean exactly?
Well, I mean that we might think of these, you know, the overestimation of fear and so on, as a response to a real thing in the world, but an over-response. But it seems to me you're suggesting that there's a built-in in these particular patients, a built-in neurological tendency to have these responses, and then there's something that provokes them.
Actually, I don't know that I would go that far, because I think with the stage that we're at right now, we're trying to understand what's going on at these different levels, and I don't think with this research design we can actually say anything too distinct about sort of the developmental ordering or progression of these processes. So that's why in this last slide, with the diagram, I want to leave it open to thinking about ways that that the mental representations and the biology could have these mutual influences. So really with some, like a design like this, it can't allow us to really know that.
Any other questions for Jeff? Yeah.
Thanks. Presumably, different sensory modalities develop at different paces in human development, and presumably, or we might imagine possibly that the different emotional components, the valences of those sensory inputs from different modalities have different trajectories for becoming integrated or feeding, activating the amygdala. Could it be that these studies are tapping on a particular state of development when visual stimuli in particular had exceptional valence compared to other sensory modalities?
Well, I mean, I think that's a very interesting question. But for me, like the first association I have to that is if you think about early experience, it's really about being exposed to both the visual and the linguistic environment, right? So, you know, the way that language helps us to internalize and the way that our visual cues in the social environment help us internalize, again, I think it's really complex in a way that we don't yet fully understand. But I don't know, does that answer what you're, yeah? Okay, thank you.
So before Luis talks, I just want to say two things. One is I see a lot of new faces in the audience, which is great, and I want to make sure that if you guys want to find out about our upcoming events, that you sign up on the mailing list downstairs. If you don't need CMEs, you can just go ahead and sign that list. That little icon right there. The other thing is I wanted to acknowledge that one of the great supporters of our research grant program over the past few years is actually in the audience. So I just wanted to acknowledge Henry Kaminer, whose family foundation has been very generous to our research grant program. So thank you, Henry.
Hi. So I wanted to thank the other presenters as well. There's a lot of overlap between what we're studying, and particularly I think Eric did a good job of introducing a lot of the same things that I'll be talking about. So again, my name's Louis Ripoll. I'm just beginning my clinical research fellowship at Mount Sinai in the Bronx, VA. And the title of my talk is Empathic Accuracy and Borderline Personality Disorder. Again, I don't. This is research that's ongoing, and so I'm just going to try to give you an idea of my thought process behind planning ongoing and future research. So a lot of this was covered, I feel like, pretty well by Eric. I just want to highlight a couple of things, particularly that an experience of intense intrapsychic pain unrelated to external events is thought to be prominent in this disorder, frequently associated with interpersonal dysfunction and a history of childhood abuse or neglect. This inner pain is often prompted by abandonment, includes a prominent component of shame, and can lead to dissociation. Symptoms of borderline personality disorder seem to occur in a certain interpersonal context for the individual, precipitating a well-defined but unstable, chaotic pattern of affective lability, impulsivity, and self-destructive behavior. Also recently, evidence suggests a role for certain neuropeptides like oxytocin, vasopressin, and particularly endogenous opioids in normal attachment and affiliative behavior. And each of these might be an avenue for psychopharmacologic treatment of personality disorders. In particular, I guess people think of endogenous opioids as sort of an intrinsic pain reliever. And in brief, a recent conception of BPD as a disorder of endogenous opioid dysregulation has face validity in terms of associated self-injurious behavior, which has been mentioned, and also the interpersonal dysfunction that you see in the disorder, as well as any potential link between the two. This theoretical orientation also allows for an explanation of the disorder that both accounts for the dynamic impact of the environment on mental life as well as the evidently high heritability of borderline personality disorder in families. Again, this was sort of covered before as well, but unlike patients with autism, for example, the deficits in affect recognition in BPD, if they exist at all, are subtle and contextualized. In BPD, empathic deficits appear to be more similar to that seen in something like psychopathy than autism, in the sense that borderline patients have greater difficulty with sort of the affective associations to others' mental states, rather than a cognitive appraisal of others' thoughts or intentions. Under conditions of low arousal, borderline patients perform as well or better than controls in a morphed faces task and in the reading of the mind and the eyes task. Some of that research was done by Eric Fertuck, obviously. In addition to this, we've found that although BPD patients demonstrate heightened psychophysiologic reactivity and amygdalar hyperreactivity in response to emotional stimuli, they also demonstrate a blunted subjective rating of those emotional stimuli. So this disconnect between objective physiology and subjective experience bears some resemblance to the construct of alexithymia. And so we sought out to look at alexithymia in borderline personality disorder. And this is part of what we found. First of all, we replicated previous research findings in terms of finding higher rates of alexithymia in the borderline population. This is with a self-report Toronto alexithymia scale. As you can tell, the borderline subjects are more alexithymic, and particularly in two subscales, the identifying feelings subscale and the describing feelings subscales. Though not shown here, we also found borderline patients did not differ from controls on a self-report measure of empathic concern, which is the tendency to react with concern and sympathetic behavior to another's suffering. Borderline patients did report a reduced ability to take the perspective of others and greater personal distress when confronted with others' distress. Also, borderline patients with higher alexithymia scores were more likely to report lower self-esteem in social situations and greater dissociative symptoms. Given the pattern of findings involving heightened amygdala and psychophysiologic hyperreactivity but blunted subjective ratings of emotional stimuli, we wondered whether alexithymia might be the driving factor in the interpersonal dysfunction seen in borderline personality disorder.
Can you talk a little more directly into the mic?
Sure. Okay. Thanks. So we examined a subset of this population of borderline subjects and healthy controls, each group with varying levels of self-reported alexithymia in a social affective response task. And in this task, subjects were asked to reflect on standardized pictures from the IAPS picture set, which is an international affective picture set. These pictures, the ones that we chose, depicted interpersonal content, and all the pictures have been standardized and normed as negative, neutral, or positive in emotional valence. Subjects were asked to either imagine themselves in the picture and rate the emotional valence, or to rate the emotion of actually an identified other in the picture. So we chose to compare the self-relevant versus the other relevant emotional appraisal, given the pervasive disturbance of identity seen in borderline personality disorder. So the results that I'm presenting, at least, and the main results we found were significant for the IAPS pictures of positive valence. What we ended up doing was we divided up the control group and the borderline group into high and low alexithymic subgroups. So the high alexithymic controls, again without any axis 1 or axis 2 diagnoses, demonstrated less positive ratings of pictures while imagining themselves in the picture relative to rating the emotion of an other in the picture. This is sort of predictable given that the alexithymia prevents them from accessing their own pleasure. But interestingly, the borderline patients demonstrated the opposite pattern, with low alexithymic borderline subjects appearing like high alexithymic controls and rating themselves less positively relative to the other condition. So high alexithymic borderline subjects rated the emotions of self and other more similarly. These findings, although confusing at first, provided only limited support for the hypothesis that alexithymia drives the interpersonal dysfunction seen in borderline personality disorder. We instead theorized that alexithymia might function defensively as a safeguard for borderline subjects from their inability to experience interpersonal pleasure and this characteristic kind of abiding experience of intrapsychic pain. Again, the phenomenology of this pain likely bears some resemblance to pervasive shameful self-concept and the experience of insecure attachment. Also, recent research by Schmal and several others has demonstrated a higher threshold for physical pain in borderline personality disorder correlated with greater rates of dissociative symptoms and self-injurious behavior, which I believe was mentioned as well. Just a very basic background on mentalizing. There are several different processes individuals use to understand emotions in themselves and others. And I want to distinguish between a more explicit process of deliberate mentalizing about self and others, as well as a more implicit, automatic process of mirroring others' mental states. In this second process, similar neural representations are engaged both during one's own actions and when you're observing others performing an action. This is the familiar mirror neuron story. It's likely that our ability to generate representations of others as simulated in the self might ground our ability to understand other minds. Deliberate mentalizing, though, might require inhibition of this process of automatic mirroring, which would otherwise result in prepotent assumptions that others have access to the same thoughts and feelings one is experiencing oneself. With only mirroring, the brain is unable to distinguish between one's own behavior and the observation of others' behavior, and the individual remains susceptible to something people have described as emotional contagion. I just want to also highlight previous research by Bartels and Zecchi, who basically concluded that love is blind insofar as reflection on romantic or maternal significant others resulted in greater activation of opioid and oxytocin-rich appetitive reward regions and deactivation of several neural networks associated with deliberate mentalizing. So, I just want to explain the conceptual framework for my current research. I'm going to be talking about something called experience sharing, and this essentially involves sharing a similar emotional experience with another person. It's likely underpinned by what I've described as automatic mirroring. And then there's another process that's been called empathic understanding, which probably also involves more deliberate kinds of mentalizing. The link between experience sharing and what I've talked about as empathic concern or expressing sympathy or concern for others is both intuitive and empirically well validated. But the specific role of empathic understanding of the mental states of others in a social context is also likely to be important for interpersonal functioning. Turns out that self-report trait measures of empathy are usually better measures of experience sharing, but these don't correlate consistently with tasks measuring empathic understanding. So I sought out to study empathic understanding in borderline personality disorder. So in collaboration with Jamil Zaki, we're looking at how patients with different personality disorders actually perform on an empathic accuracy task, or this EA paradigm. This paradigm has several advantages, most notably that it provides a naturalistic measure of everyday mind reading. And this measure of empathy is unique also based on how it's scored. A variety of healthy targets end up being videotaped discussing certain emotional experiences. And then these targets watch themselves in these videos and provide a continuous rating of their own emotions, from positive to negative using a 9-point Likert scale. Then in this paradigm, another group called the perceivers watch these same videos of the targets and perform the same continuous rating with the same Likert scale. Empathic accuracy is then defined as the degree of moment-to-moment correlation between perceivers and targets' continuous ratings. So this is just another depiction of that, in which you'll have a target speaking about an emotional experience. As you can see, there's this rating scale underneath that the subject will be watching. While each subject will watch each of these about 2 to 3 minute video clips, they'll generate this kind of a tracing. Then, sorry? Well, I mean, the main point is that as you can see, this will be the target's ratings. So you'll have a tracing that the target will generate about themselves. And then when the next group, who are called the perceivers, watch the same video clip, they'll make their own tracing. And at the bottom you can see varying levels of correlation between the two. This being a high accuracy and this being lower empathic accuracy. It turns out that in past studies, people have looked at the kind of automatic mirroring sorts of processes in terms of observing people experiencing pain or disgust or performing certain actions or facial expressions. And this seems to recruit what's been called a mirror neuron network and several other brain regions as well, including the inferior parietal lobe and the insula. Also, people have looked at more explicit mental state attribution or theory of mind tasks and have found the medial prefrontal cortex, the temporoparietal junction, and some temporal areas in those types of tasks. It turns out that when controls have been analyzed during this empathic accuracy task, they end up recruiting both types of brain regions, meaning some from this automatic mirroring network, particularly the inferior parietal lobe and these sort of premotor cortices, and some from the mental state attribution, more explicit network, including the medial prefrontal cortex. There's overlap between these regions and the default mode network, which is a network that's active when there is no explicit task. I think, well, I don't want to go into great detail about the theories about the functioning of this resting state or default mode network, but I want to just suffice it to say that most neuroimaging studies examining mental state attribution also seem to recruit regions of this network and also point out some findings in the group that I'm working with that looked at inpatient teenagers, people who had been admitted to the hospital teenagers that had been admitted to the psychiatric hospital who were subsequently diagnosed with borderline personality disorder. And they found less structural connectivity in a specific brain region that connects different areas of the default network. So what I'm presently doing is I'm running a group of control subjects, a group of borderline personality subjects, very similar to the recruitment that Eric Fertuck described, but also a group of patients with schizotypal personality disorder, and running them in this empathic accuracy paradigm. There's a little bit of variation in that I'm asking the subjects both to rate the person in the video, just as I described to you, but during some of the video clips, they're asked to rate themselves. And so, you know, they provide a continuous rating of their own emotional state while they're watching these video clips of people discussing their emotional experiences. We're measuring psychophysiology in terms of their skin conductance level, which is a sort of a measure of their arousal. And a subset of these subjects will perform the same task in the functional MRI. The other thing we're doing is we're asking each subject questions about how similar they are to the target, how likable was the target, the person in the video they just watched, and how important was what they were saying. And we're going to try to do some correlations between that, because it may be possible, and in fact there's some anecdotal evidence to this effect, that the patients seem to be more invested in what the targets are these target videos than the controls, at least the borderline patients. So in an effort to sort of better capture what clinically appears to be a fairly contextualized difficulty with mentalizing, a future version of this task might pair it with a rejection paradigm, and this is sort of similar to what's already been discussed, actually. This would essentially affect an experimental condition of more or less attachment insecurity that might provoke opioid dysregulation and might highlight the dysfunctional mentalizing that sometimes is seen in this disorder. One possibility would include a demarcated rejection paradigm, basically in which a subject provides certain information about him or herself in an effort to partner with someone, but then is rejected by that specific partner, who's a confederate, basically. This type of paradigm might share the naturalistic quality of the EA paradigm, but appears clinically relevant to borderline personality disorder. So I'm interested in looking at how rejection might affect empathic accuracy, psychophysiology, and functional neuroimaging. Yep. So other future questions, I mean, a lot of this is similar to, I think, what others have already discussed, but whether empathic accuracy is affected by attachment history or classification, the quality of object relations, similar to what Jeff has discussed. Does empathic accuracy differ according to age or developmental stage? If we were to look at different individuals diagnosed with BPD, even would it differ according to the course of the disorder? Also, are there correlations between how a person performs on this and other personality dimensions? I just want to say thanks. My research mentors are Antonia New and Larry Seaver, collaborating with Jamil Zaki and Kevin Oxner and Jennifer Bartz, and that's my newborn infant, a month old.
Could you speak for just a moment about the validity? This is sort of probably a question that goes back to even the first presentation, but could you speak to the question of the validity of the functional MRI data? When you're using self-reports, obviously you're going to have a larger N just to look at the reliability, the responses, and the variability. But when you're looking at MRI data, what's the N of the study, and how do you look for, when you identify a region, confident are you that you can say this function relates to this region of the brain?
Well, I feel like that's a fairly controversial subject, I think, even still to this day. Most neuroimaging experiments have typically much smaller numbers than other types of psychology studies even. And part of the reason for that is that you're actually generating the whole volume of the brain, first of all, over the course of multiple time points. And so there's really, it depends on what you mean by N. N in terms of individuals is actually quite small, but in terms of images, in terms of the computation that's involved, these things get quite complex, and I think in some ways that gives people less faith in the particular brain regions involved. But I should say to the opposite, to counter that, I guess, on the other hand, this is basically looking at differences in blood flow, essentially, or really, oxygenated hemoglobin to various different parts of the brain, and you're looking at averages over several groups. I think with that caveat in mind, I'm fairly confident in most of the results that certainly that have been presented here and in a wide variety of the literature.
Thank you. As somebody who's worked with domestic violence issues and the victims for many, many years, borderline is often said to be highly correlated with the victims of domestic violence. Not an assessment I would agree with, but can you speak to the implications of your research for treatment, knowing that this population is highly resistant to treatment?
Yeah, I'm just trying to think in terms of domestic violence, actually. I mean, I would argue that a lot of the situations that result in personality disordered patients either being the victims of violence or the perpetrators of violence, because whether domestic or otherwise, some of these patients actually tend to also be quite aggressive. There's some other data from our my group that that indicates higher levels of aggressive responding, but at any rate, I don't want to confuse the issue with that, but I guess what I'm saying is that I believe that a lot of these things are contextualized in certain interpersonal situations that have to do with misrecognition of different types of social stimuli. I think Eric has talked about this in terms of trust. I'm also looking at it in terms of these videotaped interactions and trying to see whether essentially the patient's understanding of the other person that they're dealing with is the same as the person they're dealing with's understanding of whatever they're presenting. And I think if we can somehow improve, if we can somehow minimize that gap, that disconnect between what the patient is thinking essentially and what whomever they're dealing with is thinking, whether it's therapist or domestic partner, that should essentially be the goal of treatment. Now, whether that happens pharmacologically, whether that happens through psychotherapy or both, remains to be seen.